Welcome to our grand rounds, and great to be here in person in the room.
Yes.
I don't know, I can't turn the computer around, but you can see we have a lot of people in the room, and it's nice. It's a nice change to be back together now and again. And I'm delighted to be able to introduce our speaker today, Dr. Jane Simoni, who I've had the pleasure of working with over the last couple of years. So she's a licensed clinical psychologist and a professor and director of the clinical training in the Department of Psychology at the University of Washington in Seattle. And she directs a behavioral core for the UW Fred Hutch CFAR, where she's a senior advisor to the eHealth Scientific Working Group. Her research has been focused on behavioral science and on disparities around HIV treatment. And I have had the pleasure of working with Jane because she took on a role for the AIDS Clinical Trials Group, leading a new effort to integrate behavioral science into our therapeutic agenda. And I can say from my firsthand experience, she has a wonderful ability to bring people together and get them working towards a common goal, and has done so much to help us understand the behavioral issues that impact people's ability to benefit from all of the interventions that we have for HIV prevention, treatment, and extending into cure. So really excited to hear her talk about the behavioral science agenda for HIV therapeutics today. So thanks, Jane.
Thank you, Judy. That was a very generous introduction. And I can say, as leader of the ACTG, you model all those things. So I appreciate those same qualities in you. I'm thrilled to be here in person. I said I won't do this talk unless I get to be in person. So I'm gonna stay after for lunch. Please come and chat. And it is just wonderful. There's just something different about a face-to-face interaction. So today, let's see. Yeah, sorry. Today we're going to talk, first I'm going to start broad, a little bit of the value of behavioral and social sciences research, abbreviate BSSR. I'll talk about the frameworks for how to incorporate BSSR into HIV therapeutic research. And then I'll talk about very specific uses and methods of BSSR and how to do that for corporations. It's fine. It's no problem, no problem. It's a maze here, I know. And then we'll talk about what are specific barriers to BSSR and strategies for successfully overcoming them to do more integrated biobehavioral research. I'll just send a couple. Most of the, I'm doing an overview. I'm not talking about specific studies, but I'll do just a couple on long-acting ART. And then we'll have conclusions, discussions. I'll leave at least 10 minutes for questions and try to give you time to get to your next meeting. And I can probably take most of the questions at the end. If there's something you need for clarification, please raise your hand. I'm happy to take it. And people online, please ask questions. Dami's going to be monitoring that as well. So lessons learned. I want to start with a few lessons learned first. Why should we incorporate behavioral and social sciences research into the broader HIV and biomedical and clinical enterprise? Well, when asked to reflect upon mistakes in his tenure as NIH director, Dr. Francis Collins said, maybe we underestimated in research on human behavior. And this was especially in context of the COVID epidemic, in which we had really medically miraculous vaccines, but 1 out of 5 Americans still haven't taken them. And this was, according to Judy Auerbach, the grand oy vey heard around the country and COVID that, yeah, maybe we should have focused a little bit more on behavior. Also, former NIH director Dr. Tom Enzel oversaw over $20 billion in federal funds when he directed NIMH, and he sharply shifted the focus away from behavioral research towards neuroscience and genetics. He now has a book that's come out last year on healing, and he confessed, I should have been able to help us bend the curves for death and disability, but I didn't. For the most part, these advances in neuroscience haven't yet benefited patients. And finally, I saw this in the New York Times the other day that the departing chair of the White House Council of Advisors, Dr. Cecilia Rouse, repeatedly emphasized the need for humility when she talked about Biden's approach to the COVID response. And she ended her tenure saying, sometimes I wish in the course of the last few years, I wish my PhD were in psychology. Yeah, it can be helpful. Without attention to behavioral and social research, the promise of even the greatest biomedical breakthroughs can fall short. Oral prep can be, should be, kind of isn't yet a game changer because of still low uptake and initial resistance from some HIV care systems. This stigmatization of it as PrEP, quote, whore stigma in the community. These are behavioral factors that need to be addressed before a biomedical intervention of PrEP can really be implemented. And in the VOICE trials, of course, we learned that you can't determine a product's efficacy if people don't use it. There's a false dichotomy. I think I've seen in HIV research. There's like on the treatment, cure, vaccine, the bench, the biomedical research versus everything else, which is lumped into kind of prevention efforts. Because it's like, if you can't cure it or treat it, then just try to prevent it. It's the next best thing you can do. And that must be all behavioral or non-clinical. And it's kind of this dichotomy is really the hard science versus the soft science, which I think is kind of ironic because in so many ways, the prevention, the quote prevention side, the behavioral side of this research is in some ways a lot harder. It's harder to measure the things. It's harder to even conceptualize them. So in some ways, I think it's the more difficult science, not like the softer science. And I would say this, often it's only viewed as applicable again in this realm of prevention, because if you can't really do what we want to do, which is cure it, treat it, get rid of it, then we can just, next best thing is just, we can prevent it in some way. And actually this is, the NIH talked about this. They said in behavioral and social sciences play a key role in HIV prevention work, research, because every single strategy that we use for preventing the acquisition or transmission of HIV has one or more associated behavioral component that can influence its efficacy. And these may affect the adoption and acceptance of an approach, or may be critical in determining how it's used, how much it's accepted, and ultimately its potential efficacy. This is really true for prevention research. But I'm arguing today for therapeutics, for treatment cure research, it's also true. Behavioral science is an integral part of it. One doc said, listen, anything you're doing to a human being has a behavioral side to it. It is essential to making trial research valid and interpretable, and if the products are successful, to making them acceptable to communities and widely adopted with no disparities in uptake or effectiveness. So there's a big role of behavioral and social sciences research, not just in prevention around HIV, but also in the therapeutics and the trials. And we can give some examples of this. It was a study we did. So all my work is my favorite picture of, viral suppression rates, how they increased over time. But you could see, though, despite much better drugs over time and no particular increase in adherence, we still have glaring disparities with younger age and African-American race predicting lower viral suppression. So it's beyond medication. There's something also about behavioral factors that are at play here. Behavioral social science research can be highly impactful. When we do conduct rigorous behavioral studies, we see results, even on biomedical outcomes, such as viral suppression, and even at the range of different kinds of interventions. I'll just review a couple of studies. This was a review of all psychosocial interventions to promote viral load suppression. It was a systematic review of clinical randomized trials and shows effects across the board for viral load. Steve Safran's study that I had a chance to be a consultant on and treating depression, improving adherence in South Africa. You showed that when you do both at the same time, you do even better. So compared to the control condition, the CBT intervention was able to decrease viral load and improve depression at the same time. And there are studies that have been evolved around the world using in Haiti an EMR-based alert. If you have some kind of bioinformatic or medication or chart review with an automated alert, you can let providers know when non-adherence might be a problem, and this can improve outcomes. We had the Shikamana intervention for gay, bisexual, and other men who have sex with men in Kenya, also showing that when you have counseling and you address both provider concerns and patient concerns, you can have an acceptable intervention with good results on adherence and viral load. And then in India, a behavioral adherence intervention improves rates of viral suppression, also a large behavioral component that can have an effect on viral load. And in other places as well, community-based versus standard clinic-based services for HIV, and the long-term effects of family-based economic empowerment intervention. You can do point-of-care viral load testing. You can use financial incentives. So a lot of ways that different kinds of behavioral interventions can really play a big role in in these trials. So when you think about how do we integrate behavioral science, what are ways we can integrate it into trials to have the biggest impact on the actual running of the trials? And this is a figure that I love from Mike Sturrett and Paul Geist a few years ago, talking about how can BSSR be integrated into trials. And they talk about just fundamentals, the pillars of this work, where you have, so the basic, you can see my cursor, you have the basic understanding of vulnerable populations and risk settings. It's, akin to the basic science, research lab science and the clinical work. You can have elemental BSSR, so improving behavioral and social risk factor reduction, and then supportive, strengthening biomedical product development and clinical trials. And this is, I think, the big role for therapeutics. It's more in the supportive realm. And then integrating it, contributing to implementation at all levels. Again, cutting back on disparities and making sure there's equitable access to these products once they are developed. So really, this is supportive BSSR. To say a little bit more about it, it's really critical to designing prevention, treatment, and cure. So BSSR information and support really need to be considered and incorporating at all stages in the very beginning planning, in the implementation, the data collection, the analysis, what variables you look at, moderating effects, mediating effects, what are the behavioral components of that, and an interpretation phases of any clinical trial of a biomedical product. BSSR can be integrated into all stages of biomedical product development. It will strengthen the clinical trial and help optimize the ultimate uptake. So it's called supportive BSSR. I really think of it as essential, because how can you not have this? How can you have a trial that really doesn't incorporate these factors and not be able to answer the questions that you're asking of the trial? So there are other different frameworks for thinking about this. This is one on how biomedical HIV prevention trials incorporate behavioral and social sciences research. And it's more a typology of different approaches. So you can have, I know you can't read this, there's a couple slides that are great, but I included them. Trainees don't do this. You're not supposed to have slides you can't read, but I wanted this to be a complete slide set so you can refer to it later, but I won't go through the whole thing. But the idea that there's typologies of ways to incorporate behavioral science. So it can have a formative approach, and that's before you even do the trial. You have to think about how behavioral science is important. It can be embedded into the trial during your actual running of it. It can run parallel. You can do sub-studies that are parallel to a trial. You can have explanatory studies. Maybe you find something. Why didn't this product work? Well, did people take it? Did certain people didn't take it? Did it interact with something like depression or some other physical condition that had an effect? You can do some of this research afterwards. And implications, even after the trial, you can look at implementation and see how it can be rolled out, or what are the implications for your findings. So this is a different kind of typology about where in the process you can incorporate BSSR. The ATM, the Microbicides Trials Network, has done a lot of work on and a good job of integrating behavioral science into their trials. And they look at also in different kind of buckets of what you can do that. So into the process itself, what are effective practices for conducting this kind of research? Looking at integration, how can you integrate it into ongoing trial development? Presenting choice, there's been a lot of research about choice. How can you offer choice? What are the methods for doing that? And what choices will people favor that will help you design product development? And measurement, especially things like adherence, shows up in basically every clinical study. How do you do that? Can you just ask people? Do you have to do some kind of fancy drug monitoring device? But that's when behavioral science can be very helpful. And not just measuring it, but supporting it. Do you actually need adherence support? So people will do what they're supposed to do during the trial, so you can find out whether or not it worked. And then engagement. And this is important through every stage of the trial, but particularly in the beginning, building effective relationship with communities, especially with diverse populations who are often underrepresented in the scientific personnel side of the study. There are ways, this is what Corinne Dubé did, and Mike Sturrett talked about specifically, and another slide that you can't read, but I'm telling you the basics is, this can apply specifically to something like cure research. So looking at basic, elemental, supportive, and integrative BSSR, what does it look like in cure research? What kind of things will you study? How would you design a study to look at these behavioral factors? And if you really want to have answers about how eventually this kind of cure research is going to roll out, or the products from it are going to lead to good uptake, you need to incorporate some of this behavioral studies first on. Tia Morton and Mike Sturrett also did a special mini conference on long-acting therapeutics and extended delivery approaches, and talked about what was the role of BSSR in these products and in the research around them. And they have different priorities, furthering scientific understanding, especially of the end user needs, their desires, their context, why they would want to do long acting, when it would be appropriate, and then developing tools and approaches to lead regimen choice and use, and then advancing innovative healthcare delivery. Behavioral social science research, not just for individuals, right? It's healthcare systems and how things will be rolled out and that lead. So another good reference for people looking at the long acting, and we'll end with a couple more examples of this too. And then finally, Ira Wilson said this can be beyond just a trial, but all aspects of the research. And they were talking about cure-related research as well. But in a phase 3 trial, there's not just the study, but ethics around it. Do people know what they're getting into? How do you test that? How do you assure that they are? What's the best way to explain what's going to happen in the trial to make sure they understand? What are their preferences around even being in the trial? Whether they agree to join up in the trial? Do you look at refuses in the trial and find out, making sure you're getting a very representative group of subjects from your population? Working with stakeholders and their engagement, applying methods developed early on to make sure that they're engaged in the trial. How do you communicate about the trial? How do you advertise about it? How do you talk about your results? Equity and disparities, health systems research. Again, it's not just the individual, it's the larger community that you have to deal with and larger health system. And then health policy research in general, very broad, very large, goes even beyond, again, individual factors, but looking at policy research. And this is important for cure research. Okay, Dami, on my screen, how do I get rid of that top bar that's blocking some of the, I'm sorry. I never, can I pull it, move it somewhere? That's not gonna, how do I make it smaller? I always wondered this in Zoom too. How do I? Okay. Which one here? Controls. All right, thank you. Everybody take note of that. I don't know how many Zoom controls, I don't know how many Zoom meetings I've been on. I haven't been able to say the titles of my slides. I don't know. 3 dots, remember that? Okay. You learn a lot in this talk, see, about behavior. So I talked about different ways, different rubrics, typologies, how do we incorporate behavioral science into these trials, but what are the actual methods? Like, how do you do it? Do you just talk to people? Well, there are more and more sophisticated ways to do this, and just go through a few of them. So in-depth interviews, you can of course talk to people and you can ask them questions about what they're doing, but we have a really better science in how to do that now. And we wrote this study about using brief reports, so debrief reports, so it doesn't take months and months after you've done the interviews to find out what you actually found out. You can get a debrief report, get some key points, and get right back that week to the investigators. Do we need to change something about the trial or what we're doing? So I really encourage people to use in-depth qualitative interviews, but to think about more accelerated ways to get the information back to the trial investigators. Focus group discussions, there's different, sometimes you want a group of people, you want them to feed off of each other. Sometimes, especially with highly stigmatized information, you want personal questions, so you go with individuals. You can use computer-assisted self-interviewing, so you don't have to have a person face-to-face if you think people won't feel comfortable sharing information. There's conjoint and discrete choice experiments. Jay's an expert here. You can use those kind of techniques to look at choice within the context of other choices. So you just don't ask people, do you want the more expensive kind or the less expensive kind? Because we know what people are going to answer, right? So you want to know what combinations of choices they'll want and what are the trade-offs they'll make around these choices. You can do ethnography, really, which helps when you're doing studies in new contexts, body mapping approaches, when you're talking about effects on the body, the debrief reports I mentioned. You can use interactive voice and short message kind of paging or like texting type data collection, other kinds of interviews. You can analyze sessions. You can do pile sorting, so that what people put things in order of what they want. So all the way to market research and interviewing couples and families. So a lot of different approaches that involve either individuals or groups of individuals to get at the kind of behavioral information that you need. So to go into a little bit more deep, I'm going to take these one stage at a time and give you examples of what you can do in each. So getting back to supportive research and HIV therapeutics research, because that's what I was asked really to focus on today. So I'll talk about product development first, right? Then its use, the social context, the trial design itself, how to deal with measurements, assessments, the adherence monitoring and promotion and support that you need, and then community integration and implementation. So these are all areas in trials that I think are important. So I'll just give a few examples of each of how to do it. So product development, you have a new product, you want to roll it out. Are people interested in it? Do a little pre-trial development. It's important. David Bangsberg used to say, before you do a $125 million trial, spend $125,000 to find out if people will even ever use the product that you're investigating. It can determine preferences and likely acceptability. There's no way, you have no crystal ball when you're asking people to think ahead about what they would do, but you get some idea, especially if they're very strong reasons not for using the product. And sometimes you can change things early on, or how you present the product that will address these issues. So qualitative methods are good for these, and focus groups, as well as I mentioned the more sophisticated quantitative methods like conjoint analysis and increasingly discrete choice studies. And then actually using the product, how should you look at that within a trial? BSSR data can yield information on actual product use. Did they actually use the product? Before you say it doesn't work, you have to make sure they did. What were the potential barriers to be addressed? Were there certain people, or certain times of the day that certain people didn't use a trial or couldn't? And what about acceptability during early clinical trial changes? You can decide, it can guide decisions on which products, which dosing intervals, and which supports are needed, and do it early on before you set up a very expensive trial in which you're not going to get the answers to the questions you want. MTN, again, was very good on this. When they focused on product development, use, and introduction, they had research on acceptability, whether people wanted it or not, had very good studies on that. Adherence, the best ways to measure it, how to support it. And social factors, they're very good at looking things in context. I did a lot of microbicide research. It was women in partnerships, often with men. So there was a contextual component to this. Are you involved in sex work? Do you have a family? Do you have multiple partners? So the social component was very important. And most of our studies are really with the individual, right? So this is a chance earlier on to look at a broader influence. So social and contextual factors in the community. We can't just take a trial and transplant it over to South Africa and think it's going to run exactly the same as it did in the United States. What are ways you have to look at contextual factors and change it? Sexual behaviors, how do you ask about it? And so many other cultures, it's most cultures, it's very private information. How do you ask that in a way that people will feel free to share their private information? And multi-purpose prevention technology, what product characteristics influence choices and preferences? All right, so the community context, supportive behavioral and social science research can provide systematic data on the key populations and communities. Not everyone responds the same way to products. Not everyone's as interested. They all have different needs. Your local environments, again, it could vary when you go to a different place to try to implement something. The HIV landscape in that setting are different groups. At more risk, is there more stigma towards one group or another, or even HIV? And even the social and historical context of researchers going into the Deep South with history of Tuskegee. What is it like then to come in and say, I'm going to do another study on a sexually transmitted disease? What is that like, and how will that influence what I'm trying to do? So robust, triangulated means more than one measure, multi-level data, along with ethnographic surveys, participant observations, can yield important insights into these complex systems and experiences for navigating HIV prevention and care. So community context is critical. The trial itself, we do RCTs, is it as simple as that? Well, BSSR can strengthen the design, the implementation, and the interpretation of the trials. So early testing of proposed trial procedures, good to do pilot testing when you see if this is the way we're going to recruit participants, are they going to agree? Or we're just not going to get any women in the study if this is the way we do it. We need to know that earlier, not when we start the trial and only have 10% females. You need process evaluation. So during the course of the trial, looking at how things are working, to evaluate feasibility and to identify any operational obstacles. And qualitative studies of the user experience. These can be done throughout the trial. Actually, like say at ATI, at these analytic treatment interruptions, or ART. How do people feel before, during, and after these interruptions? And do it in real time as they're going through the study. Especially around consent, they agree to a trial, you can ask about their decision-making. What went into it? What were the factors that led you to participate or not? Do you understand the consent? Do you know what's actually going to go on in this trial and how it might affect you? And this is a way to limit harms. And exit interviews. I love exit interviews. Have you ever done them at the end of the trial? The first question you ask is, what was the study about? People don't even know. Or they'll say, this is a study that really helped me take my medications. You know, that pill bottle was great. It was the control condition they were in. So, but they were sure this study was going out to help them. And this is true even people going to doctor's appointments or surgeries. There's research showing that people forget surgeries they had 10 years ago. I was in a study, a longitudinal study, like 5 years ago. And it's a full day study. People come, get paid. And the investigator said, most of the people don't even remember baseline. Their lives are just so busy that they don't remember that. A little personal side. I remember after my first postpartum interview, I was talking to my doctor about it. I was so glad to finally get back, you know, busy with the baby. And she said, Jane, this is your second one. You were here before. It's the baby. And I was like, no memory of it during that time. So exit interviews are really important and can give you a lot of information about what's going on in the study. And people will, and don't ask them things like, did you tell the truth in the study or did you lie on those questionnaires? What you say is, how accurate were you able to be when you told us about, you know, your adherence in the study? Well, you know, pretty accurate. That means not very. So if you can talk to people and give them a chance to really tell about the study, you know, gosh, if I was in a study like this, I don't know that I could have stayed on that protocol the whole time. Were you able to do it at all? Oh, yeah, a lot of days I did. You know, that's what you want. You mean every day you didn't? Okay, because you said you did in this protocol. So having people open up and helping them tell you about the study in the way they can actually talk to you at the end is very important. And there are good summaries of studies about how to do this, specifically around trials, the planning stage, conducting the trial, during the closeout, and dissemination. So another good reference you can look at in more detail later. What about measurement and assessment? Such a key part. Redoing interventions. So much of the work in biomedical trials is basically like a biomedical, where you get a test, a lab of something. You don't really have to talk to people, but when you're doing behavioral measures, a lot of it still is self-report, right? And of behavioral and psychosocial factors that can really be key when you're trying to understand what went on in the study. So mental health is key. Sometimes it's a moderator of the effects. Sometimes it's a direct outcome of the study. People actually feel better after they're in the study that wasn't even targeting depression. Anxiety, PTSD, quality of life measures, adherence, you know, has a whole field written about how to do that. But you need good psychometrically sound measures that were tested for the communities and the languages that you're using them in. And there are good measures of these now. You don't have to always pay for them. Most of them are funded on NIH research, and a lot of investigators like Ira Wilson who are willing to give you their measures, PHQ for depression, generalized anxiety measures that are available that have already been translated into dozens of languages. And if we use those, and NIMH is pushing now for big harmonization about measures. We have to be able to compare what we're doing. And just imagine the field of meta-analysis. This is going to transform meta-analyses when you actually have the exact same measures in all these studies. And we can do a much better job of doing that. But really interested more in harmonizing within like the networks, across the networks and across the field, so that funded studies doesn't have to be just NIMH. I think it really should be an NIH-wide effort to harmonize studies and assessments that we do. Yeah, so adherence, assessment, monitoring, and promotion. Like I said, there's a whole field just around this. But sometimes it's not just good enough to measure it. You really have to help improve adherence during a trial. And there are ways to do that. Like we said, there's been an impact on a lot of behavioral studies on viral load and adherence. Often it's in the form of brief theory-based counseling. And Geist and Starrett have said that this is an essential component of any clinical trial. If you want people to take the new product, you have to help them to do it. And there are evidence-based approaches to do that. It doesn't mean you just have the person come in and tell them you better take this drug or my study's not going to work. There are ways to do it that open them up to talk about the challenges that they have, to help them be able to take the medication. And we know how to train counselors and supervise them. You work one-time workshops, not enough for someone. Was that enough for any of us to learn any skill we've ever done? And from driving a car to learning to do stats, you had to have supervision, you had to have practice, and it's the same thing with counseling. Coaching and counselor support is important to gaining new skills, and you need fidelity monitoring. You have to actually ask what people are doing in studies after you send them out. Okay, and then community integration and implementation. Again, this should be throughout the whole part of the study. Community member perspectives are essential to trial success. They can provide insight, and they are critical, especially to recruitment. Michelle Andrasik's done a lot of work at HVT, and she worked in the COVID trials, increasing underrepresented group participation in clinical trials through community engagement, and recruitment goal establishing. When they first started doing the infusions for BNABs, they thought, oh my God, no one's going to come in here and do this. And she talked to the community. They had really good media. They had excellent products to describe what was going to happen in the trial. And once they started, they had no trouble. They beat their goal of recruitment and they stopped their study that was going to look at refusers that didn't have enough. So you can have success if you do this the right way and do it early on, really in a thoughtful way. And I say for the third time, it addresses disparities, both in the efficacy and uptake. You want a trial study that's going to give them information on how this is going to be applied to all communities. There are also ways to look at behavioral research for supporting adoption and implementation. So once you've done the study, once you've shown it's effective, how do you get it into communities who need it? How will this be implemented? How will we measure and support its use? Who will take it up? How will they take it out? What's the likely impact? How can it be transferred? What about costing? I haven't even mentioned. I consider that a kind of BSSR costing and just looking at effectiveness. And how can it be explained to end users? How do you promote and advertise the intervention once it's out? So you need communication about that and the value of it locally. So these are some of the factors that go into actually implementing the intervention when it's out there. So in summary then, supportive, essential BSSR, when used from planning stages to interpretation of outcomes, can really improve development and clinical testing of biomedical products. It facilitates selection of the best ones, the identification of adherence support that you'll need, and will ensure really proper proof of concept testing. It helps plans for better executing better biomedically centered intervention and better product-oriented research. Now, there's some barriers. If this is after this talk, it's like, oh, obviously we should be doing this. What are the barriers to it? There's simple just ignorance. People don't see the need. They've never done it. They were never taught it. It seems to, so there's just to have that value has not been well articulated. And I think that the onus of that really relies on the behavioral and social sciences as well to get that message across. Traditional large pharmaceutical trials really were focused on, quote, compliant patients. So people who were going to take it, they wanted the drug to work, they wanted people to do it, but they didn't want to have to say they had an intervention component. So they just gave it to people who pretty much they knew would take the drug and hoped it worked. And there's also some kinds, just a blanket refusal or dismissal that can be kind of active. I really don't want to waste my time. I don't see what you get out of just talking to people or asking questions. And that is a certain perspective. And I think that it's largely uninformed. So when we have good evidence to show, to counter that, it can be helpful. And then sometimes it's an active avoidance, not really wanting to know. You have a study where you're giving 17 pills a day. You're kind of thinking no one's really going to like this. If you actually talk to community members, they'll be like, I'm not doing that. I don't want to do, but you already have the pills. You're already ready. You want to go out and do this. So there is just an avoidance of, let's just see if we can get this to work. Maybe enough people will take it. We don't actually want to have the information because we know it might not be good. There's restricted funding. There's qualitative interviewers. They have to be trained. The analysis is long. It takes a while. That might not have been included in the original study. Some funding agencies just don't account for it. And maybe you just don't have the expertise on the team. Not anybody can do this. It's not as easy as asking someone questions. You really do have to have specific training in it. And if if it's not done well, it won't be as helpful. And then sometimes it's just, operational, there's expediency. It just don't take too long. We're ready to go. We want to get it out in the field. It just is, will just take that much longer and cost that much more. So there are a lot of barriers. So how do you surmount that? There are a lot of ways to think about it. So continue just to conduct these impactful behavioral science studies, like I showed in the beginning. They show they have an impact on viral load, on actually biomedically important outcomes. And when you show that, people are more likely to engage in that kind of science or see the value of it and publicize the advantages of it, like we're doing now. Form interdisciplinary teams. It's important to work together and talk. We each speak a different language in our different disciplines, but make sure we understand and share that kind of research. Harmonization, support that among the networks, across our studies, across the institutes at NIH. And really lobby NIH, talk to your project officers, can there be more funds in this, and can you actually require, CFARs don't have to have a behavioral core, they have to have an admin and developmental core, but it would be nice to at least say you must consider, behavioral factors, how they affect what you're doing. And then propose behavioral and social science investigations within networks where possible and where they're relevant to the aims of the study. Those are some ways to begin to see the better science. I'm going to end just with a couple of examples of some of the research we're doing on long-acting injectables. So the study with Susan Graham, and we're as long-acting treatment options come on the market. We want to know, there's more for PrEP now, but we want to know about treatment. Will people be open to doing these? So we conducted, this is an R01, took place in Seattle, Atlanta, and in Kenya. So first started with key informant interviews, talking to people in the field. What do they think products are going to look like? What should we be asking about? Not just injectables, but our implants, something we should think about. And then we used a DCE, discrete choice experiment design, choosing between either of two hypothetical options, and I'll show you, or just sticking with your daily oral art. We developed and pilot tested a survey in DCE with 50 participants to start, then moved on to 350, both in Seattle and Emory. We'll analyze these data, and then we'll repeat this process in Kenya, which we're doing it now. So don't have the results for this now. We're presenting at the Adherence conference, and some are in press in AIDS. And this is what it looked like. So you have your option A, your option B, or your current regimen. What should you really have? Let me explain this to people. There's a little video that goes through it, but these were the attributes that we had: the treatment type, long-acting pills or injection; location, do I have to go to a pharmacy? Can I take it at home? Frequency, how often would I have to take it? How much pain would I feel? Do I have to wait a time before to see if I'm undetectable? Is there any negative reaction testing I'll have to do first to make sure I'm allergic to it or some contraindication? And then late dose leeway. Can I be late and take it? Will it still work? So you have to go through these and think about option A or B, or what would you prefer? Just stick with your current medication. So that's the kind of work we're doing on this with long acting. And then Mike Stewart and I had a chance to address the arts committee of the ACTG. And I'll just tell you a little bit about what we talked about. That's also important for trials. I want to give Mike credit for this. We using a theory-based approach. So there are dozens of theories in behavioral science research. Some of these, this COMBI model just looks across them like, well, what are the main, if you had to do like a factor analysis, what are the most important parts of most theories? And you can pretty much get down to capability. If you want to change someone's behavior, you have to target their capability. Can they actually do this with? And you might do skills training, education. Mental health can be a barrier. Their motivation, what encourages someone to do this? Do you need motivational interviewing to help tap into factors that will get people to do something? And then opportunity, this kind of gets at some of the wider social determinants. These have to be addressed before you can change behavior. And basically, when you're doing clinical trials with they become hard to reach, but really hardly reach is a better way to describe them, populations, you need multiple forms of support. Just like with monotherapy didn't work, highly active antiretroviral therapy had a combination that works better with behavioral interventions as well. And we need to meet deeper needs. If we're going to do these therapeutic trials with folks who are really not doing well and not suppressed, people with adherence and care retention challenges often have comorbid concerns, and they're not simple and easy to address. So mental health, substance use, chronic houselessness. And what are options then to address these? You get what you pay for. If you have low resources for staffing and cost, you still can do something. You can use standard tools, regularly stay in contact, use locator updaters, use electronic ways of staying in touch, give some travel reimbursements. But if you have more staffing, as you can say, you can do more. You can have enhanced motivation. You can have conditional incentives, i.e. pay people sometimes, or have them participate in a lottery. And if you really have the resources, intensive case management does work. Outreach workers, you have a van, you go out to the community. You don't have to come in. If we're talking about a shot that ultimately has to be given once every 6 months, an injection, maybe you can go out and find the people and give it to them. And then all the way to community-based care delivery models, adherence clubs, or going out in community. So really a range of different things you can do, but get what you pay for. You need the resources to do the higher end stuff. And if you want results, you probably have to do more than one approach. I want to stop there, leave some time for questions to go on. Thank you.
So question one, thank you for that incredible overview, and I really appreciate it for being a little late. But I also really like your perspective on bringing in sort of the historical experience. I find it interesting you cited
NTN as an example after the voice trial, which is also one of the colossal failures of.
I mentioned that too. I did mention that as well.
Yeah, but I thought that was really helpful to have that perspective. And also, I'm going to read these questions that we got from the chat, but I want you to then give us a little reflection on the CFAR, which is differently structured from our CFAR, and sort of your perspective as a co-director of the CFAR and a behavioral science person that does that, and what the sort of role of your behavioral science core does and is that specifically in the CFAR. But that is something to chew on while we read these. So first question is from Michael Luella from the chat. And he said, hi. And
Hi, Michael.
I agree BSSR is essential, but it feels to me that it is underfunded in HIV therapeutics research. I think you mentioned that though. Do you have any ideas of why this might be? And do you have suggestions on how we might change this as community advocates?
Michael, great question. Maybe you wrote that before the slide on barriers. I hope I covered most of them. But doing some of the work you're doing, going into the community, educating individuals about recent findings and getting feedback is important. In terms of advocating, I think it's not just at the level of studies that are already funded. I think to do it sooner, to talk to program at NIH is one way to do it. I think we have to change the request for the proposals and what for instance, what the CFARs have to fund, what the trials have to fund. I think that's a better way to go about doing it. And one of the studies that I did on acceptability before this long-acting one, I think Mike Sturt actually wrote into the RFA that you had to have a component. They actually mentioned doing some kind of conjoint analyses. That's when we worked with Jay on that. That I think was written into the funding proposal. So I think that's a good level to start at, to really have a bigger impact. Talk to the funder directly, not those getting the funds.
So another one is from Alistair Burton about trial phase 3s. I don't see any involvement of community participants in the development of this trial as compared with asking participants to give responses to the BSSR. Did I miss something? Not quite sure I understand the question.
Okay, I'm not sure. He did have an Ira Wilson's slide. He did talk about stage 3 trials. And maybe it's true one of the columns wasn't community involvement. It certainly should be. I think at one point I said community should be involved throughout. And I want to make a point for more community folks going on to get a higher degree and get involved and actually conducting the studies and leading these studies, not just consulting on them. But yeah, community should just definitely be involved in phase 3 trials and in every trial from beginning to end.
Is there anyone in the room before there's more in the chat. Let's see if there's somebody in the room that has a question before we go back to the chat. Judy does. Okay.
Great, thanks. Really great. So this idea about kind of taking an inventory of the participant of what are going to be the issues that might challenge their adherence during this study. So has that ever, can we predict that at the start and then tailor the intervention to what we learn at that point? Or is this really something that evolves over time and can't really be predicted from just one point in time?
Yeah, I mean, we often rely on the literature, right? Because we know so much now about the barriers to adherence and what we expect. But I think when there are new therapeutics talking about it in this, and we think there are particular challenges to them, like the infusions, you have to go in, you have to be there for a certain amount of time. I think we can predict there are going to be challenges around that. So is there going to be childcare issues? Are there going to be transportation issues? Do they have to come during the day, during working hours? Because that's when the clinics open. Some of that stuff I think you can anticipate early on. And sometimes you don't even have to ask the people. You just know that's going to be an issue, or this drug can't be taken, or has to have some food restrictions or something. When you know those are going to be issues, then I think you can predict that early on. But I think in doing the formative work, you always ask people. You can always ask about it. But whether you can identify, surely exactly what those issues are going to be, I don't know. It's hard to say. Yep. Oh.
Thanks, Jana. One of the studies I was involved was mental health when served by LGBT serving organizations. And it was before COVID, with the group counseling intervention, and one of the main issues was that people had transportation issues, and so a lot of people didn't receive intervention, there was no significant intervention effect, partly because, it has occurred to me with Zoom revolution that there might be a lot of behavioral interventions that like that could be more easily implemented over Zoom. But then I'm also struck by you were very insistent on doing this, grand rounds in person. I'm curious from your perspective on Zoom or other remote distance implementations of interventions and how they interface.
Okay. Yeah. What about, Tom's asking, what about remote options for interventions? A lot of times interventions don't work because people didn't get them. They couldn't get into the clinic to get the intervention. So a very timely question about what can you do virtually and what do you need to do in person on. I think we're still learning that. I think we're collecting data on that. I'd like to see some data-based answers to that question, not just preferences, but certainly in teletherapy, telehealth. Care, I know I'll speak in with the counseling that we've done at the University of Washington, attendance has gone up in a lot of ways. It's not, I think, in some areas, I think in some of the coursework, I think students dropped out. It was less engaging. But with the therapy, people were able to attend more when they didn't have to park at the university. They didn't have to drive in. They didn't have to get childcare. So we actually had, for those who were there, we actually had better attendance. I think it's a way to address inequities in access because it ends up, in effect, being less expensive to be able to come, less resource intensive to be able to come. But now a lot of agencies are dialing that back and saying, no, if you want to get reimbursed, you have to have in-person sessions. I think we really need to look at that. And think about the advantages of having that. And if we can do it in a safe, virtual environment where there's privacy is protected, I think we should continue it. There might be ways to, I think it's important, the initial sessions, this is what I found, initial sessions, you're meeting with someone, have that be in person. And even if you guys found at work, when you having Zoom meetings with people you knew and you've worked with 20 years, it's not so hard. When you're starting a new study and they're all new people on the Zoom, it's terrible. So my heart went out to the ninth graders, and the seniors kind of could pull it off in high school, but the ninth graders in school, starting high school on Zoom, where they didn't know anybody in the class, was horrific. So I think there might be some way to hybridize this so that you can use the technology in a way that's helpful, but not detracting from the advantages or the times when it isn't. And I think it's true for, physical healthcare too, as well. I know a lot of doctors, a lot of doctors loved it. A lot of patients loved it, not going in. Others, one doc told me he has a patient drives 2 hours each way to come in, will not do something online, wants to be in person in the room with the person. So I think it's going to be like with this, it's going to be some kind of hybrid. Last question about the.
Well, it's interesting, I just funded these 3 initiatives, the limited the light one, limited interaction, targeted epidemiology, to see if we can reach people that are hardly reached through some online interventions. And so they have them for young MSN and people intervention, Southern women, and then they have one that who are not very 1,000 people in each cohort, multiple ones, only online. So I think we'll find out, right?
Yeah, that's good. Yep. Yeah, that's great. I didn't know about that one. Do you want me to end with that question on then the CFARs, what to do if there's anything else? Yeah, I mean, I'll be honest, we didn't have a core for a long time, at least the first 15 years. And even when we had, I think Karina Walters and I had the first NIMH funded behavioral HIV study there, we weren't even invited to be in the CFAR. So also there was a in the first core, we weren't even involved in it, even though we had, and there were folks in social work doing behavioral studies on HIV. So it was a while to actually integrate it. There was a need that was seen for it, but I think they had a mathematical modeler running the behavioral core. That was as behavioral as they could go at that point. But it took another couple sessions where we had a full-on behavioral science core that was really about adherence, mental health, substance use as well, with support on intervention development and theory-based interventions. So we really focused on those things. And we had that at the UW Fred Hutch CFAR before we had Birch. So now we have an ARC, just like CHIPTS, right? We have a AIDS Research Center. And we made sure in our applications, because being director of one and co-director of the other, I saw the application at the same time. I made sure we showed synergies but not duplication or overlap, right? So we couldn't be doing the same thing. So what were we doing in Birch that we weren't doing at the other center? So we focused on a different content area. We focused on integrated care, which wasn't being covered at all in the CFAR. We focused on methods, had a full-on methods core. There was never enough method support for behavioral work at the CFAR. They couldn't even do factor analyses. I mean, like they couldn't do an alpha. It was like crazy because every question was just like one test or one lab. So there was a real need for that. So I showed the needs, the gaps in service at the CFAR, and promoted the Birch as something that was going to be in combination with that. So it was, I think, a real strength of the proposal that we worked so closely with the CFAR. We had some overlaps, like some of the positions of people on Birch also worked over at the CFAR, and almost everything we co-sponsor, we do together. We try to double attendance that way. And we started a group. I have a junior investigator group, which I've been running for about 12, 13 years. And it's for folks who have biomedical health training, public health training, who want to incorporate behavioral science. You don't have to go back and get a PhD in psychology. You can incorporate behavioral science into your studies with some support from an expert. So that was, I think that was really an incubator for a lot of the behavioral science work at UW from that. So happy to talk more about that.
One more question, sorry, about cost effectiveness. What extent you're doing that as far as BSSR?
Yeah.
So two articles discussing behavioral interventions with cost effectiveness data, especially in low resource.
Yeah, great point. I personally don't do it, but we have a big center. We lost Rowan Barnabas recently, who was leading one at UW, but a very important part. I consider it part of behavioral science, but cost effectiveness and costing a very important part of the study. And I say, and we do need it for behavioral approaches. I think, as we might find out, it's not as expensive as we think. You know, there's often saying that we can't afford to do it, but and I worked at a pediatric obesity study. We can't afford 16 sessions. It was just way too expensive, but it was the only evidence-based way to point the kids in the direction of low BMI. So in the end, much more expensive not to do it. So I think it's a great question. We do need more data on costing for behavioral interventions. With that, should we wrap it up, Amina? Okay. Okay.
It's not going to be.
Okay, I can hear him.
What? 68?
Where's Jeff?
Hi, I'm not hearing. Did you want me to ask my question?
I can hear you.
Can you hear me? Hello?
Yes, do you have a question?
Yeah. Well, a comment and then a question. So you'd mentioned the need for having, community folks involved in the trial design process. And, fortunately, that's been integrated into the ACDG for some time now. The problem we're encountering is that, as the epidemic moves on, people get older, they have to lead lives again. 30 years ago, it was life or death. People dropped everything and ran to volunteer to do this. That's not an option for most people anymore. Right now, I think we only have 3 people from the US on the CSS of the ACDG, and 2 of them are set to roll off. We just don't have qualified people to serve on all the protocols we've got doing, especially the really involved cure protocols that you were talking about. So we really need to, just like we're funding social behavior research, we need to think about funding community involvement if we're going to have quality involvement going forward. It's just not going to work. I know, correct me if I'm wrong, but as I understand it, not all of the BSS members and the ACDG are funded for the work they do, and they're basically volunteers in the protocol team. And that too is not really sustainable. We need to think about how we fund that going forward so that we get the input you were just talking about.
So thank you, Jeff. I think you guys could hear that Jeff made the comment that we need to fund community involvement in the trials, and we don't have as many